Okay, so today we are going to deal with some of the spinal cord injuries as well as some of the spinal cord diseases, lesions of the spinal cord. And we will see how these injuries and diseases present and which part of the spinal cord is affected in which of the diseases as well as syndromes of the spinal cord. So there could be, what you need to see is this an acute or a chronic set of symptoms. So you can make out an acute problem to the spinal cord, which is within, after an injury or trauma or something, or is it a, chronic problem which is because of compression to the spinal cord or by a tumor or a chronic degeneration of the spinal cord with progressive symptoms. So you need to, when you look at the symptoms, you need to make out, is this an acute problem or is a chronic problem? And you start to make out, oh, this is a degenerative disease, it's a progressive disease, is it a trauma? So that you need to make out. And also what you need to make out is, this is a complete, damage to the spinal cord, if this is a complete transaction, or it is an incomplete syndrome. Usually when you would see spinal cord syndromes, these are incomplete syndromes. They are not complete damage to the spinal cord, either in trauma or in other lesions of the spinal cord. Usually what you would find that symptoms represent incomplete injuries or incomplete damage to the spinal cord. So we rarely see a complete damage at a particular level. It is, an incomplete type of syndrome. So incomplete, there is absence of, if there is a complete transaction of the spinal cord, there would be complete absence of sensory and motor function. And you would actually, if you do per rectal examination, you would find there is no anal reflex. There is a complete transaction. All sensory motors function in the perianal region would be lost. Now, there are certain terminologies which you would keep on hearing, like plegia. Plegia means complete paralysis. Paresis means some muscle strength is preserved. So when you hear the word plegia, it means complete paralysis. When you hear the word paresis, it means some muscle strength. There is paralysis, but there is some muscle strength which is preserved. Tetraplegia or quadriplegia means all four limbs are paralyzed. So injury of the cervical spinal cord, patient can usually still move his arms using the segments above the injury. In example, in C7 injury, the patient can still flex his forearm using the C5 segment of the spinal cord. But usually tetraplegia means all four limbs are paralyzed. When we use the terminology paraplegia, it means the injury of the thoracic or lumbosacral cords involving, and thus both lower limbs are not working or they are paralyzed. So any injury to thoracic or lower thoracic or lumbosacral cord or corda equina can lead to paralysis of both lower limbs, and that is called paraplegia. Hemiplegia means paralysis of one half of the body, and usually these are lesions above the spinal cord level in the brainstem or in the cerebrum. So when you see half side of the body paralyzed, the complete half side of the body paralyzed, you start to think, especially if it is involving the head and neck region also, then it is in the cerebrum. If it is not involving the head and neck region, only half side of the body is involved, then it is above the spinal cord level. So you just by having one symptom, looking half side, one half of the body is paralyzed, you'll think, oh, this cannot be at the spinal cord level. This should be above the spinal cord level. And if you see complete half side with head and neck also involved, should be above brainstem. Now, there are certain things which you do to assess the muscle strength. For example, you start to abduct the shoulders and you put your hands on the shoulders and ask the patient to abduct. You are basically testing deltoid, and the segment of the spinal cord you are testing is C5. And you're looking at, put your hands on the shoulder, ask the patient to abduct the shoulders. You are testing the muscle strength within the deltoid, which is applied by C5. Similarly, you can test the elbow flexion. That is the function of the bicep. And if you are testing the extension at the elbow joint, which is the function of the triceps, so you can test C6, C7 triceps reflex. If you are basically looking at the elbow extension, you're looking at C7. So this is how you are basically testing which spinal cord segment is involved by just doing simple things. Asking the patient to abduct, you are testing C5. Asking the patient to flex the elbow, you are testing C6. Extend the elbow, C7. Wrist flexion extension is C8. Small hands, small muscles of the hand, you ask the patient to grip your fingers. This is basically small muscles in the hand, which is T1. If you want to ask the patient to flex the hip, it is iliopsoas, and the segment you are testing is L2. If you are extending the knee, this is quadriceps, and you are testing L4. And if you ask the patient to dorsiflex, this is the extensor hallucis longus, and the segment you are testing is L5. And if you are doing plantar flexion, that is the gastrocnemius, the function of the gastrocnemius, and the segment is S1. So by just testing different muscles, you can easily identify which segment of the spinal cord is involved, because you would find weakness and you can grade this muscle strength from 0 to 5. How you grade them? If there is no contraction, 0. If there is a flicker of contraction in these muscles, it is 1. If the movement with gravity eliminated, that means if you put the hand under your elbow and then start to flex, you are removing the gravity. So that is the strength at 2. And then movement against gravity, if you can perform, that is 3. And then movement against resistance, you offer resistance and then you are performing, you can judge. If there is a movement against resistance, then you can grade it as 4. And if it is normal strength, then it is 5. So this is how you grade the muscle strength. And I've already given you different muscles on which you can identify which segment of the spinal cord is involved. Similar is the case with the sensory. So you have all these levels and you can see different places which they represent. So how you test sensory innervation? You test by taking a pinprick. You can do a cotton wig, which is a crude touch. And with pinprick, it's fine touch. Then you can use a tuning fork, which is a vibration. And you can also use some, a hot test tube to put at different places to touch to look for temperature. But once you are, eliciting pain by pinprick, you don't really need temperature. But you can test temperature, you can test vibration, you can test touch, fine touch as well as crude touch by using cotton wig and pinprick, as well as tuning fork for vibration. So those type of things can be tested at different landmarks, and you can see these different landmarks represent different dermatomes. So this is how. That's why you would see that most of the neurological examination, which is mainly motor and sensory, and then the third piece is the cranial nerve. So you in most of the neurological examination, what we are doing is a motor examination, we are doing the sensory examination, and then we are testing the cranial nerves. So in motor examination, you need to check the strength of the muscles. And I have given you the list of the muscles and how you are going to test these muscles. This is your one of the part of the motor examination. Then you need to do a sensory examination, and you need to do all the dermatomes and see, or you can skip. You can use, for example, you can do shoulder, and then you look at the umbilicus, and then you go into the lower limb, and you find out, to where the site of the lesion is. And once you have an idea, then you can go further down and precisely identify which area or which dermatome is affected. The third thing which you do in the motor examination is also to look for deep tendon reflexes. And the common ones are bicipital reflex, which is done on the tendon of the biceps, which represents C5. Then you have the styloradius, which is on the brachioradialis, which is C6. Tricipital is at the back of the tendon of the tricep, so that is C7. Patellar is at the knee joint, and the Achilles one is at the ankle joint. So these are the 5 different reflexes, the deep tendon reflexes, which you do. What you would find, either you would find no reflexes, which is usually in the lower motor neuron type of paralysis. And if you find hyperreflexia or clonus, that is in the upper motor neuron type of paralysis. The other 2 ones which you see are, one is the superficial reflex, which is the Babinski sign, which also is present in the upper motor neuron lesions. What you do at the sole of the foot, you put, you take a thick thing, move it around the plantar aspect of the foot. Usually the toes go down and they come together if it is normal. If it is abnormal, then it would be fanning of the toes like this. The fanning of the toes means Babinski sign is positive and you have an upper motor neuron lesion, or it can be like this in children less than 1 year of age whose corticospinal tract is not myelinated. So those who have corticospinal tract not myelinated, as in children infants below 1 year of age, you can find Babinski sign positive. But this is usually in adults a sign of an upper motor neuron lesion. Clonus or hyper-exaggerated reflexes or any of these is also a sign of upper motor neuron lesion. If it is lost, then it is these tendon reflexes, deep tendon reflexes are lost, then you are looking at a lower motor neuron lesion. And since you know the segment they represent in the spinal cord, you can also use deep tendon reflexes to identify the site of the lesion. Now, there are 2 types of shocks which you would hear. One is the neurogenic shock, and the other is the spinal shock. The neurogenic shock is seen in cervical injuries, and it is due to the interruption of the sympathetic input from the hypothalamus to the cardiovascular center. The hallmark of the neurogenic shock is hypotension and bradycardia. So if you see in a cervical injury, hypotension and bradycardia, this is neurogenic shock. The brain tissues, when they get injured, they the neurons stop discharging, their activity for a period of time. So whenever you have either the head injury or the spinal cord injury, the neurons within the spinal cord and the brain will stop discharging electrical activity for a period of time. That is called a shock. And in spinal shock, what happens is that the neurons within the spinal cord will stop to discharge electrical activity for a period of time just below the level of injury. So wherever you have the spinal cord injury, below that you would have stopping of the firing of the neurons for a period of time. That is called spinal shock. So imagine if your anterior gray horn cells are not firing, what would happen? Hyporeflexia, flaccid type of paralysis. So that would happen in spinal shock. Whenever you have spinal cord injury, for a period of time, the spinal cord neurons will stop firing, and it can last from 48 hours to a week that these neurons are not firing. And that's why you would not be able to determine the injury, because all neurons are not firing. So you would have bilateral type of flaccid paralysis and loss of tone below the level of the injury. So you cannot actually make out how the injury is there. So you need to keep in mind, after any spinal cord injury, there could be a period of time when the spinal cord neurons are not firing and they are in spinal shock. So the neurogenic shock was due to sympathetic fibers not firing, and as a result there was bradycardia and hypotension. Here, this spinal shock is because all the neurons in the spinal cord are not firing. So you have hypotonia, loss of reflexes. And the way you check the spinal shock is usually you do an anal reflex. So usually if you pinch the tip of the penis or the clitoris, there is contraction of the anal sphincter. So in spinal shock, because none of the neurons are firing, even if you pinch the tip of the penis or clitoris, there would be no anal reflex. So this is how, when you get a patient with the spinal cord injury, you check if the patient is in spinal shock or not, and when he is recovering from the spinal shock, so that you can do a examination and find out the motor or sensory losses because of the spinal cord injury. Now we are going to talk about some of the spinal cord lesion. The first one we are going to talk about is the spinal muscular atrophy. This is more of a congenital degeneration of the anterior gray horn cells of the spinal cord. And it usually is a congenital, so it is, you find at birth, the patients are floppy baby with marked hypotonia, flaccid paralysis, and tongue fasciculation. There is a problem in the autosomal recessive inheritance of mutation in SMN1 gene. This is also called Wernicke-Wolfman disease. So what is the problem in the spinal muscular atrophy? That there is a degeneration of the anterior gray horn cells. It's a congenital degeneration of the anterior gray horn cells, resulting in lower motor neuron type of paralysis. There's floppy baby with marked hypotonia and fasciculation of tongue. Major problem is in the SMN1 gene, where there is a mutation which results in this type of problem. The amyotrophic lateral sclerosis is an example of a mixed motor problem. It does not have any sensory component, but in amyotrophic lateral sclerosis, there is a mixed motor problem. What you are seeing is that there is degeneration in the anterior gray horn cells and also degeneration of the corticospinal pathway. So if there is degeneration of the corticospinal pathway and there is degeneration of the anterior gray horn cells, The anterior gray horn cells, degeneration in the anterior gray horn cells will result in lower motor neuron type of paralysis, while the degeneration of the corticospinal tract will result in upper motor neuron type. So it's a mixed type of motor disorder with no sensory involvement. So combined upper motor neuron and lower motor neuron degeneration with no sensory or bowel or bladder deficits can be caused by the defect in this enzyme, which is the superoxide dismutase 1. So in pathology, you would learn more about it, that the amyotrophic lateral sclerosis is a mixed type of motor disorder. It's not a mixed motor sensory, it's a mixed motor disorder where you would find both upper motor neuron and lower motor neuron lesions with no sensory deficits, with no involvement of autonomic fibers. So that's why you do not find any bowel or bladder deficits. But they can present both upper motor and lower motor neurons can involve the spinal cord as well as brainstem. That's why you can see dysarthria and dysphagia, which are because of the muscles of larynx and pharynx in the brainstem. It is also called Lou Gehrig disease. So if you hear the word Lou Gehrig disease, is the same as amyotrophic lateral sclerosis. Then we have the anterior spinal cord syndrome, and the anterior spinal cord syndrome usually happens because of the occlusion of the anterior spinal artery, because we said there is an anterior spinal artery which supplies the anterior 2/3 of the spinal cord, and there are two posterior spinal arteries which are going to supply the posterior 1/3 of the spinal cord. This part, the anterior 2/3, is supplied by the anterior spinal artery, and it is there is a watershed area at the level of, because not only the anterior spinal artery is supplying here, but the intersegmental arteries from the aorta are also supplying. One of the key arteries is the artery which is coming from the aorta, which is the T8 intersegmental artery. Now, if you are performing a surgery on the thoracic part of the aorta, sometimes that T8 artery can be compromised. And as a result, there would be ischemia to the anterior part of the spinal cord, leading to the lesions which involve, if you see anterior part, there might be bilateral anterior gray horn cells which are going to be affected, resulting in lower motor neuron type of paralysis. Then bilaterally, spinal tract are going to be gone. So you would have the upper motor neuron type of lesion bilaterally below the level of the ischemia. You would also lose pain and temperature bilaterally below the level of the lesion. So the anterior spinal artery, if it gets occluded, or there is a problem while you are performing a surgeries on the abdominal, on the thoracic part of the aorta, and if the T8 artery, which is a major contributor to the anterior part of the spinal cord, is affected, then you may have a problem in the anterior part of the spinal cord, leading to upper motor neuron deficit below the level of the lesion and lower motor neuron deficits at the level of the lesion. And then you would also lose pain and temperature bilaterally below the level of the lesion. Tapes dorsalis is a condition which happens because of the tertiary syphilis. Syphilis is an infection which happens, it's a STD, which is the sexually transmitted disease, which can affect the nervous system also. So initially, the syphilis, the primary syphilis, affects the sexual organs, but the tertiary syphilis can affect the brain and the spinal cord, and mainly the spinal cord is affected. And if you see here, it results in demyelination of the dorsal column. And because of the demyelination of the dorsal column, you remember that the dorsal column is important in two-touch discrimination, vibration, and proprioception. So proprioception usually get lost because of the tapes dorsalis, which is the tertiary syphilis. And as a result, what happens is that you would not be able to have the sense of your joints. So when you're putting your feet on the ground, you cannot make out where you are standing or which part of your foot is touching the ground. As a result, you have problems in balance. So you have progressive sensory ataxia, impaired proprioception, poor coordination. You are unable to localize the position of your joints and foot on the ground, resulting in imbalance, which is ataxia. So tapes dorsalis involves usually the posterior column, demyelination of the posterior column. It is because of an infection, which is the spirochete infection, which is the syphilis. The tertiary form of syphilis involves the spinal cord. The primary form is going to involve the sexual organs, but the tertiary form is the one which involves the spinal cord. Then we have a condition which is called syringomyelia. Now, in the syringomyelia, what is happening is that there is an enlargement of the central canal. So there is a syrinx. Syrinx means a dilatation of the central canal. Usually, this dilatation happens within the cervical segments of the spinal cord. Now, as there is dilatation of the central canal, the fibers of the spinothalamic tracts, which were crossing just in front of the central canal, are going to be affected. So if they are going to be affected, what would happen? That there would be bilateral symmetrical loss of pain and temperature sensation because there is the lamination of the fibers in the spinothalamic tract. The medial fibers represent the upper part of the body. The lateral fibers represent the lower part of the body. So there would be initially effect on the upper part of the body. The upper limbs would be more affected and the lower limbs would be spared. So in syringomyelia, usually it is the cervical part of the spinal cord which is affected and the central canal is dilated. So what happens is that you would lose bilateral pain and temperature in the upper part of the body, and the lower limbs would be spared. Similarly, the distal part of the limbs would be less affected as compared to the proximal part of the limbs. Then we have the vitamin B12 deficiency. This vitamin B12 deficiency causes subacute combined degeneration. So there is demyelination of the spinocerebellar pathway, the lateral corticospinal pathway, and dorsal column pathway. Now, this is more of the sensory motor mixed type of neuropathy, where you have demyelination of the spinocerebellar pathway, you have the demyelination of the lateral corticospinal pathway, and the dorsal column pathway. So there is ataxic gait because of the dorsal column pathway. Proprioception is lost. There is paresthesia because of fine touch is gone because of the dorsal column. Impaired position and vibration sense is also because of the dorsal column. And then you may also have an upper motor neuron type of paralysis because of the involvement of the corticospinal tract. So this is subacute combined degeneration, which is because of the vitamin B12 deficiency. It can happen because of other deficiencies also, but the major one is the vitamin B12 deficiency, which can lead to subacute combined degeneration. Quad equina syndrome, it's a compression of the spinal roots of L2 and below, and often due to the intervertebral disc herniation. Now, you know that the quad equina is arising below the spinal cord. So any disc protrusion below the L1 level will start to compress the quad equina. This will result in unilateral radicular pain. So whichever the segment the nerves are compressed, you would have the pain in that segment of the spinal cord. Absent knee and ankle reflexes, and loss of bladder and anal sphincters, because bladder and anal sphincters are supplied by S2 segments of the spinal cord. So if you have a compression of chorda equina at L2 or L3 level, the bladder control will be gone, the anal sphincter control would be gone, and plus you would have a saddle type of anesthesia. That means the area between your thighs and the perineum is the area where your sensations would be lost. So saddle type of paresthesia is a characteristic sign of chorda equina syndrome.
Doctor, is it only for L2 or
anything below L2? But usually, because the if you see the perineal segments, they are S2, S3, S4, they are all below L2. So if you have a compression of chorda equina below that, your perineal portion would be there would be sensory loss there. So usually chorda equina syndrome will present with loss of bladder control, loss of anal sphincter control. There is saddle type of paresthesia, and then pain within the segments of the spinal cord where the nerves are being compressed. Now, this is the most important piece of this session. We are going to talk about at least 4 of these syndromes, and out of these, we are going to talk mainly on the central cord, anterior cord, and brown cord syndromes. These are incomplete injuries to the spinal cord. You can have a complete transection of the spinal cord, or you can have incomplete syndromes of the spinal cord. So most commonly, you have incomplete syndromes. And these incomplete syndromes, how they are going to present. So we are going to talk about central cord, we are going to talk about the anterior cord, and we are going to talk about Brown's cord syndrome. Chorda equina, we have already talked about. Posterior cord, we don't have much, but we would just briefly mention what happens in the posterior cord syndrome. So the first one is the Brown's cord, and Brown's cord syndrome is it's not very common. It happens because of a penetrating injury, or like a knife injury or a gunshot injury at the back, which results in half of the spinal cord, half side of the spinal cord getting damaged. So if you have a penetrating injury at the back, and it results in half of the spinal cord getting injured, the other half normal, that is what we call as Brown's cord syndrome. It can also happen because of the fracture of the lateral mass of the vertebra. That can also damage half side of the spinal cord. So it is also called sometimes hemisection of the spinal cord. So hemisection, Brown's cord, is half side of the spinal cord which is injured. Now, what you would see, because on the half side, if we go from front backwards, there is anterior gray horn cells, which are the lower motor neurons for that segment of the spinal cord. You have corticospinal tract on that side, which is going down. So if it is getting injured, then you would have below the level of the lesion on the ipsilateral side an upper motor neuron type of lesion. Then you go the spinothalamic tract, which you are seeing at that segment, it has not crossed. So with the segment where it is, there is hemisection, you have pain and temperature on the ipsilateral side lost. But below the level of the lesion, these tracts, the spinothalamic tracts, are representing the other side of the body. So pain and temperature below the level of the lesion would be lost on the contralateral side. Then in the dorsal column, you have the dorsal column tracts, which are responsible for two-touch discrimination, vibration, and proprioception. So below the level of the lesion, you would have loss of two-touch discrimination, vibration, and the proprioception. So those type of things are going to be seen. So let us discuss this. This is what we are talking about. This is the hemisection. So you are losing the anterior gray horn cells at the section where you are having the injury. So at the section where you are having the injury, you have lower motor neuron type of paralysis. So within that segment, if it is C5 segment of the spinal cord, within the C5, you are seeing flaccid type of paralysis on the side of the lesion. So if it is right side, or ipsilateral lower motor neuron lesion within the segment of the injury. Then you are seeing this corticospinal tract. So if this corticospinal tract is damaged, this corticospinal tract is taking fibers to the segments below. So below C5, like C6, C7, C8, ipsilaterally you would find an upper motor neuron type of lesion. That means hyperreflexia, there would be spastic type of paralysis, so those type of things you are going to find below the level of lesion. Also within lateral part of this cord here, we have the lateral spinothalamic, and posteriorly we have the dorsal column, and we have the posterior gray horn cells. So the sensory input which is getting into this segment, in the segment of the injury, you would find complete loss of sensation. All sensation are lost within that segment of the spinal cord where the injury is happening. But below the level of the injury, pain and temperature, the fibers which are the lateral spinothalamic fibers which represent pain and temperature, they represent the other side of the body. So pain and temperature below the level of the lesion would be lost on the opposite side. And two-touch discrimination and vision and conscious proprioception would be lost on the ipsilateral side below the level of lesion. Also in the thoracic segments of the spinal cord, there is the lateral gray horns which are there, and also descending hypothalamic fibers which are there, which supply sympathetic fibers. So there might be Horner syndrome associated with the loss of the hypothalamic fibers which are present in the lateral white column. And as a result, there would be anhydrosis of the face, ptosis of the lids, if there is an injury in the upper part of the cervical region of the spinal cord with the hemisection. So these are the effects. So contralateral, loss of pain and temperature, caudal to the lesion. This is because of the interruption to the spinothalamic tract. Ipsilaterally, you would find paralysis of voluntary movement, caudal to the level of the lesion, hyperreflexia, spasticity, extensor toe sign, so upper motor neuron type of lesion because of the damage to the lateral corticospinal. Loss of vibration position sense from perception and two-point discrimination. This is because of the dorsal column. Segmental weakness and atrophy. This is because of the anterior gray horn cells. And segmental anesthesia. This is because of all the neurons which are entering the dorsal rootlet, which is bringing the sensory sensation. They are all gone. So you have segmental anesthesia within the segment where there is damage to the spinal cord. And then there is loss of sweating, caudal to the level of the lesion if the lesion is in cervical part of the spinal cord, which is the ipsilateral Horner syndrome with piloconstriction, ptosis, and hemifacial anhydrosis. So this is because of the interruption of the descending autonomic fibers. So if the lesion is within the cervical piece of the spinal cord, the descending fibers from the hypothalamus to the sympathetic neurons within the thoracic piece of the spinal cord would not go there. So you would have on half side of the face anhydrosis, there is no sweating, ptosis, which is the drooping of the eyelid, and there would be miosis, which is the constriction of the pupil. So these are the features of Brown-Scott syndrome, which is the hemisection of the spinal cord. Now, central cord syndrome is much more common. It's the most common type of the spinal cord syndrome. What happens usually that there is constriction of the spinal canal, or there is cervical spondylosis within the old age people. There is degeneration of the vertebra in the old age people, and if they have a whiplash type of injury where your neck goes back like this, there is a ligament at the back or degeneration of the bones at the back. So the spinal cord is compressed in the center. So the central piece of the spinal cord is compressed because there is rigidity at the back, and you have a whiplash type of injury. Your head goes back like this, and there is either degeneration of the vertebral column, or there are projections coming out from the vertebral column, or the vertebral canal is narrower. So what happens is that if you have this type of injury, hyperextension injury of the neck, the central part of the spinal cord is going to be affected. So typically in older patient, hyperextension injury, compression of the cord anteriorly by the osteophyte and posterior by the ligamentum flavum. So in between them, because the canal becomes narrower and you have this hyperextension type of injury, the cord is compressed in the center, resulting in damage to the central piece of the spinal cord. Central cord syndrome can also be represented as syringomyelia, where the central canal becomes enlarged and it is going to damage the area in front and lateral to the central canal. So syringomyelia also represents as central cord syndrome. It can also happen in old patients because of a whiplash type of injury. So more centrally situated cervical tracts tend to be more involved, hence flaccid weakness of arms is more than the legs. So again, like in syringomyelia, what you usually have is more of because the fibers of the spinothalamic tract as well as the fibers of the corticospinal tract. The medial fibers represent upper limb. The lateral fibers represent lower limbs. So you would have more problems in the upper limb as compared to the lower limbs. Lower limbs are spared, upper limbs are more affected. Perianal sensation and some lower extremity movement and sensation may be preserved. So there is more involvement of the upper limbs and there is less involvement of the lower limbs. So this is what happens here. So you have a cervical injury where the central piece of the spinal cord is affected. You can see the fibers of the spinothalamic tracts are crossing in front, so they are going to be affected here. As these fibers are going to be affected, there would be pain and temperature loss bilaterally in upper limbs, and because the lower limb fibers are more laterally located, so they are spared. Similarly, corticospinal tract fibers, the medial part of the corticospinal tract fibers represents upper limb, and the lateral piece of the corticospinal tract fibers represent the lower limb. That's why more of the upper limb, there would be spastic type of paralysis bilaterally below the level of the lesion, both in upper limbs, and the lower limbs would be spared. So you have two features. Bilaterally below the level of lesion, you would have loss of pain and temperature involving the upper limbs, sparing the lower limbs. Similarly, you would have below the level of the lesion bilateral spastic type of paralysis involving the upper limbs, sparing the lower limbs. There would be flaccid type of paralysis in the segment where you would have the central cord syndrome. So the central cord syndrome involving those segments, you would have bilateral flaccid type of paralysis. So these are the three features which you are going to see: dissociated sensory loss of temperature and pain from the damage to the pathway, more involving the upper limb and less involving the lower limb. There would be spastic paralysis to the medial portion of the pyramidal tract, which is going to involve a bilaterally more upper limb, sparing the lower limb, and there would be flaccid type of paralysis from bilateral damage to the anterior gray horn cells in the segment involving the central cord syndrome. Then we are going to come to the anterior cord syndrome. Anterior cord syndrome usually happens because of the occlusion of the anterior spinal artery. If there is an occlusion of the anterior spinal artery, it results in the anterior spinal cord syndrome. It can also happen because anterior dislocation or compression fraction of the vertebral body, both corticospinal and spinothalamic are damaged. So if both corticospinal and both spinothalamic are damaged, so below the level of the lesion, you have bilateral loss of pain and temperature, and you would have bilateral upper motor neuron type of paralysis below the level of the lesion. At the level of the lesion, you have flaccid type of paralysis bilaterally. So these are the three features. There is sparing of the dorsal column, so you don't have loss of two-touch discrimination, vibration, or proprioception. So two-touch discrimination, vibration, and proprioception would be preserved. You would have bilaterally loss of pain and temperature below the level of the lesion. There is no sparing of the lower limb here. There is bilateral upper motor neuron lesion below the level of the lesion, below the level of the injured spinal cord, and at the segment of the spinal cord, you have flaccid type of paralysis bilaterally. So loss of power, decrease in pain and temperature sensation below the lesion, dorsal column remains intact. So this is what you are going to see. There is bilateral loss of pain and temperature, bilateral spastic type of paralysis. At the segment, you have flaccid type of paralysis. Usually, because the lesion is at T8, it also affects the autonomic fibers, so you would lose the function of the bladder and rectum. So at T8, bilaterally, there is flaccid type of paralysis. Below that, you have spastic type of paralysis, and you also lose pain and temperature bilaterally. You also lose the dysfunction of bladder and rectum is also there because of the autonomic fibers which are affected. But there is no problem with the dorsal column tracts. So there is no loss of two-touch discrimination, vibration, and proprioception. This, you compare this with the Brown-Scott syndrome. This is Brown-Scott syndrome, where you have ipsilateral proprioception problem, ipsilateral below the level of the lesion, spastic paralysis. At the level of the lesion, you have flaccid paralysis. Contralaterally, you have loss of pain and temperature. So this is a picture of Brown-Scott syndrome. Compare this with, this is the anterior cord syndrome. And then if you compare this with the central cord syndrome, you find that there is more involvement of the upper limb and the lower limbs are spared. So you need to picture these three syndromes in your mind, because many of the questions related to testing the spinal cord tracts would be related to these syndromes. Somebody is going to put either the central cord syndrome or the anterior cord syndrome or Brown-Scott syndrome, and then start to ask you, why did you find, that particular loss? Which track is involved? Those type of questioning would be there. So you need to apply this information when you are reading the spinal cord tracks, where they cross, what is their function, because this is how we are going to test you. We don't test in the exams by asking simple questions like, what is the function of the spinothalamic tract? We are going to give you a cord syndrome, and then within that, we are going to ask you, okay, why do you think that in this patient, the pain and temperature is lost ipsilaterally? Which track is involved? 1, 2, 3, 4, 5. Okay, so this is how you need to apply information. So this is a picture where you are seeing all these syndromes, where you can see here, this is the central cord syndrome, which is usually because of the syrinx, syringomyelia involving the cervical part of the cord. And we said in this, more medial fibers are affected as compared to the lateral fibers, especially spinothalamic and corticospinal. So what you are seeing, pain and temperature loss in the upper limbs bilaterally, sparing the lower limb. And you have medial portion of the corticospinal tract involved. So you would have an upper motor neuron type of lesion below the site of the injury, and it usually involves the upper limb, spares the lower limb. So this is the central cord syndrome. Anterior cord syndrome, we said it is because of usually occlusion of the anterior spinal artery. So you usually see scenarios like, somebody has a thoracic aneurysm and there was a repair going on the thoracic aneurysm. And because the T8 artery usually comes out from the thoracic part of the aorta, if it gets compromised during the repair, you have ischemia of the anterior part of the cord. So the scenario may say, a surgeon was performing, a surgery on a thoracic aneurysm, and after the surgery, patient presents with these symptoms. What symptoms would be there? The patient would have bilateral spastic type of paralysis below the level of the lesion because of the corticospinal tract involved. There would be bilateral loss of pain and temperature, loss because of the involvement of the spinothalamic. And there would be also flaccid type of paralysis within the segment, like T8 segment of the spinal cord. You find flaccid type of paralysis because bilateral damage to the anterior gray horn cells. The posterior cord syndrome happens because of the occlusion of the posterior spinal artery. It may come up with unilateral loss of two-touch discrimination and vibration below the level of the lesion. So this is posterior cord syndrome. Then diseases of the anterior horn, you might have a baby just born which is floppy. There are no tendon reflexes. So those type of things can happen because of the damage to the anterior gray horn cells. This is spinal muscular atrophy, and you might find a mutation of SMN1 gene in this patient later on. That will give you a sign that this is a congenital disease with spinal muscular atrophy. Amyotrophic lateral sclerosis is a progressive disease, and it involves both upper motor neuron and lower motor neuron. So you would find a mixed motor type of disease with no sensory losses. So there might be upper motor neuron lesion in certain segments of the spinal cord, and there would be lower motor neuron lesions in the certain segment. It may involve the head and neck region also, because amyotrophic lateral sclerosis will also involve the brainstem. It only does not involve spinal cord. So you might find, head and neck muscles, there might be upper motor neuron, lower motor neuron in different segments of the spinal cord bilaterally, and it's a progressive disease. It happens because of the superoxide dismutase 1 enzyme mutation. So you need to know about that, because pathology people will keep on asking you about superoxide mutase 1 problem with the amyotrophic lateral sclerosis. So you keep that in mind. Tapes dorsalis is the one which involves the posterior column, and usually there is sensory ataxia because of the loss of proprioception, and this happens because of syphilis. The tertiary syphilis can result in tapes dorsalis. Vitamin B12 deficiency can result in subacute chronic degeneration, which involves the dorsal column as well as the lateral column. In the lateral column, it may also involve the spinocerebellar corticospinal tract, and in the dorsal column, it can involve the dorsal column tracts. So there might be sensory ataxia along with motor dysfunction, the upper motor neuron type of lesion, because corticospinal tract is also involved. So this is a subacute combined degeneration, which result in demyelination of corticospinal tracts, as well as it can represent in demyelination of the dorsal column tract and spinocerebellar tracts. These are the tracts which are usually involved in vitamin B12 deficiency. This gives you, overview. So you can see the central cord syndrome, usually bilateral central corticospinal tracts and lateral spinothalamic tracts are involved. Hyperextension injuries, syringomyelia, spinal cord compression. Bilateral paresis, more in the upper limbs compared to the lower limbs. So this is the characteristic sign of the central cord syndrome. Anterior cord syndrome involves the corticospinal and the spinothalamic tracts, trauma, penetrating injury, or mainly occlusion of the anterior spinal artery. Bilateral motor paralysis, loss of pain and temperature sensation, and autonomic dysfunction below the level of the lesion. This is the characteristic sign of the anterior cord. Then you get the Brown's cord or hemisection, usually because of the penetrating trauma, gunshot injury, or there is the stab wound injury or spinal cord compression. Ipsilaterally, you would have loss of proprioception, vibration, tactile discrimination, and below the level of lesion because of the dorsal column. Segmental flaccid paralysis at the level of the lesion because of the anterior gray horn cells. Spastic paralysis below the level of the lesion and ipsilateral Babinski sign because of the corticospinal tract. Horner's lesion above T1. So if you have Horner syndrome, half side of the face involved, where you have anhidrosis, ptosis, and meiosis, this should be an injury above the T1 segments of the spinal cord. And contralaterally, you would find loss of pain and temperature sensation 1 or 2 levels below the level of the lesion. So this is a characteristic sign of Brown's cord syndrome. Any questions you have? Yeah.
Doctor, in the hemisection syndrome, we have contralateral loss of pain and temperature because it crosses at the level of spinal cord.
Yes, the lateral spinal thalamic. Yes.
For the anterior and central cord syndrome, why aren't we using the crude touch and pressure? Because isn't the anterior side a problem with
Yeah, crude touch and pressure is not easily, you cannot easily make out, because some of the function is also from the dorsal column, especially touch. So that's why you usually do not test crude touch and pressure. What you basically see is proprioception, which is conscious proprioception by moving the different joints at different position, because with eyes closed, because that is a function of the dorsal column. And you use crude touch only with the wig. So usually what you are basically looking at is more of differentiation between spinothalamic and dorsal column, because that would give you the diagnosis. Why do you need to do crude touch and pressure? You can do pain, temperature, those type of things with pinprick, which can easily differentiate between spinothalamic and the dorsal column. Yes.
Doctor, do you know what symptoms associated with damage to the spinocerebellar tract?
Spinocerebellar tract will result in, unconscious proprioception. So you have ataxia associated, but we are talking about sensory ataxia where conscious proprioception is affected. Conscious proprioception is the function of the dorsal column. Unconscious proprioception, like you are swaying to one side while walking, that is unconscious proprioception, and that is the function of spinocerebellar. You ask the patient to walk in a straight line with eyes closed, he starts to sway on one side. So on the side which starts to sway is the side where the spinocerebellar tracts are involved. So when you are doing the neurological examination, there are tests for cerebellar function, and the spinocerebellar pathways are related with these cerebellar functions. You ask these patients to close their eyes, stand in, with toes joined together, and they start to sway. So that type of test will tell you about spinocerebellar function. But Conscious proprioception is more like you, with your eyes closed, I put your joint up or down, you can tell that this is, my finger is up or down. That is conscious proprioception. That is a function of dorsal column. Let's see if there are any chats.
Doctor, the symptoms of pain and temperature are the same as the symptoms of crude touch, right?
Yeah, crude touch and pressure you usually do not test. You test pain and temperature, which is the function of spinal thalamic. Yeah.
For the upper motor regions, why do you have temp stimulation?
Not in upper motor, in lower motor neuron. In lower motor neuron, muscle fasciculation is one of the symptoms. So in any lower motor neuron lesion, you would find muscle fasciculation. Okay, where is the... Okay, thank you very much. Stop here.